Good morning to all of you. I am presenting the pathological part of this case. For present case, patient went for right lobe thyroid fine needle aspiration cytology, ultrasound guided. This is the smear from right lobe thyroid nodule. The smears are visually cellular and so papillary fragments and clusters of tumor cells disposed on hemorrhagic background. There was no necrosis in the background and neither matured lymphocytes or reactive lymphocytes are seen in the background. This is the higher power view of the smear, displaying the tumor cells which are disposed in clusters and tumor cells are overlapping with each other. Further higher power view showing the tumor cells having enlarged nuclei, conspicuous nuclei at the periphery, and moderate to abundant amount of eosinophilic cytoplasm. Few nuclear pseudo-inclusions are also noted in the tumor cells. This is the further higher power view, displaying the nuclear pseudo-inclusions and nuclear grooving among the tumor cells. So, conclude the cytomorphological findings of the present case. Present case showed the richly cellular smears and cohesive group of cells along with finger-like papillary fragments of cells. Tumor cells are displaying nuclear crowding and nuclear enlargement along with pale chromatin, internuclear cytoplasmic inclusions along with the grooving. So these features are characteristics of papillary thyroid carcinoma. However, few of the smears show columnar-like tumor cells. These tumor cells are having basal nuclei and abundant amount of eosinophilic cytoplasm. This is the further hyper view, displaying the columnar type of cells which are elongated and having basal nuclei and apical abundant amount of granular cytoplasm. These cytomorphological features giving the clues about the tall cell variant of papillary thyroid carcinoma. However, a differential diagnosis is very difficult on fine needle aspiration cytology smear because it overlaps with the classical PTC and columnar cell variant of PTC and oncocytic variant of PTC. These are columnar-like cells having apical cytoplasm and basal nucleus. However, it is very difficult for the pathologist to make a variant of PTC on cytomorphology because it overlaps with the classical PTC and should be mistaken for columnar cell variant or oncocytic variant or Verdine-like PTC variant. Usually, columnar cell variant of PTC is associated with necrosis and there is very subtle nuclear inclusions or nuclear grooving inside the tumor cells in columnar cell variant. And in oncocytic variant, these tumor cells are not such tall as in columnar variant of PTC. And in Verdine-like PTC, usually the background contains numerous lymphocytes. Hence, a diagnosis of papillary thyroid carcinoma suspecting for tall cell variant of PTC. Now, I would like to invite my endocrine colleague for further discussion.
So we had a diagnosis of right solitary thyroid nodule, Bethesda 6, and since it was a well-defined lesion with less than 4 centimeter largest diameter, the patient was scheduled for right hemithyroidectomy. She underwent same. We can see here the specimen. We can see here in the specimen a well-defined solitary thyroid nodule, which measured approximately 3.5 into 3 centimeter. The final histopathology of the same will be discussed with Dr. Anurag. I invite him on the stage for the same.
For the same case, we received a right hemithyroidectomy specimen and cut surface of which showed grayish-white solid nodule. This is the photomicrograph of the hematoxylin and eosin stained section, displaying the numerous tumor cells disposed in form of papillae, and these papillae are having fibrovascular core along with the scant amount of colloid inside the thyroid follicles. This is the further higher view of the same, displaying the nuclear clearing. This is the nuclear clearing among the tumor cells and nuclear grooving inside the tumor cells. This is the further magnification view of the HE stent section, displaying the tumor cells over the papillae. These papillae are having fibrovascular pores. This is the core of tumor cell, core of fibrovascular, and these are tumor cells arranged over the fibrovascular core. These tumor cells are elongated and having basal nucleus. This is the cytoplasmic membrane of tumor cells and clearly evacuated. Hence, the diagnosis of Karl cell variant was given in this case because more than 30% of tumor cells are Karl cell and having columnar appearance and along with the abundant amount of eosinophilic cytoplasm. And Karl cell is a type of columnar-like cells which height is more than 3 times of width of the tumor cells. This is the
I think we
width
can
of tumor
take
cell.
questions once the case discussion is over.
This is the width of tumor cell and it is length of the tumor cells, and length of the tumor cells is more than 3 times of the width. Hence, a possibility of hence a diagnosis of Karl cell variant PTC was given in this case. Why it is important to report Karl cell variant of PTC? Because of clinical and prognostic importance. Karl cell variant tumors are aggressive than classic papillary thyroid carcinoma tumors. These tumors have higher rate of extracellular extension, vascular invasion, and lymph node metastasis, and higher recurrence and higher mortality rate, and lower disease-free survival. Considering the more aggressive therapy for the tumor in form of radioactive iodine and closer follow-up is advised in these tumors. These tumors are usually associated with BRAF mutations, which may guide the targeted therapy in the Karl cell variant of PTC cases. When the tumor cells have 30% or more of PTC cells whose height is more than 3 times of the width and so abundant eosinophilic cytoplasm with prominent cell membrane, then it is considered Karl cell variant of PTC. These tumors are associated with older age, larger tumor size, and extracellular extension. These are more aggressive than the classical PTC and usually have BRAF V600E mutation in the tumor. These are the differential diagnosis of Karl cell variant, which includes columnar cell variant of PTC, oncophytic variant, and Vardan-like papillary thyroid carcinoma PTC. Columnar cell PTC have pale eosinophilic to clear cytoplasm, prominent nuclear pseudostratification, and subnuclear vacuoles. And in columnar cell variant, characteristic feature of PTC like nuclear pseudo-inclusions and nuclear grooving is usually absent or very subtle. However, their length is not more than 1 to 1.5 times in columnar cell variant. However, in Karl cell variant, length of the tumor cells is more than 3 times of the width. In oncophytic variant, there are tumor cells having oncophytic cytoplasm and papillae and nuclear features are same as the classical PTC. In Vardan-like papillary thyroid carcinoma, papillae are present which have fibrovascular core, and in these fibrovascular cores there are numerous lymphocytes and plasma cells are present. And Vardan-like PTC usually have chronic lymphocytic thyroiditis or hashimoto thyroiditis in their background. Now I would like to invite my endocrine colleague for the further discussion.
Thank you, sir. The patient, the post-operative period was uneventful, and the patient was discharged on post-operative day 3. She is further planned for completion thyroidectomy and whole body radioiodine scan along with the need of radioactive iodine ablation or therapy is to be considered. Her first response assessment will be done 3 months after the surgery. I will now be inviting Dr. Divya Priyadarshini to the stage to further discuss the clinical implications.
Well, that was the pathology discussion was very detailed, and thank you, Dr. Anurag, for the same. I'll just briefly touch upon some already known factor about tall cell variant of papillary thyroid carcinoma. As we have all already known, that's an aggressive subtype having more extrathyroid extension with the more invasion, lymph node metastasis, and having BRAF 600 mutation positive. So that translates into high risk of recurrence and aggressive behaviors clinically. So this needs more aggressive treatment in terms of thyroidectomy more than lobectomy. Along with that, also this type of tumors needs more adjuvant therapy in form of radioiodine therapy or ablation. And this kind of patients needs rigorous follow-up. In the new ATA classification, this has been categorized in the intermediate group having a intermediate to high group having a recurrence rate of 16 to 30%. That is why they have mentioned that this kind of patients needs adjuvant radioiodine therapy along with TSS operations. So here is a projection of the difference between tall cell variant of papillary thyroid carcinoma and classical papillary thyroid carcinoma. As we all know that these kind of patients needs more frequent follow-up and careful follow-up. So they should be follow-up like classical papillary thyroid carcinoma with PG, anti-TZ, TSH, and a ultrasound with every 6 to 12 weeks. Along with that, this kind of patients needs adjuvant, should be sent for adjuvant radioiodine therapy or ablation. Along with that, the most important thing is TSS suppression to keep in control the cancer. So these kind of patients, our tendency should be to keep the TSH towards the suppression side from 0.1 to 0.5 if falls in intermediate category. And if it falls in high risk or is there any structural recurrence, that should be less than 0.1. Coming to the surveillance part, similarly with classical papillary thyroid carcinoma, for the initial 2 years, we should follow up the patient with biochemical and ultrasound NEC for every 6 to 12 months. And if needed or if structural disease is present, a diagnostic whole body iodine scan or a BZ PET, if indicated, should be done. And if they are area refractory, as we have already known that these kind of patients are having BRAF positive, so a systemic therapy can be considered in form of targeted therapy for this kind of patients.
So, thank you. And now this case is open for comments and discussion from the floor. And Dr. Anurag and Dr. Divya would be taking up the questions. And if any intervention is needed from senior pathologists, we have